everybody. Welcome to #1 Doctor YouTube channel. Today we will talk about compartment syndrome and fasciotomy. Compartment syndrome. Raised pressure in osteofascial compartment. Elevation of pressure prevents tissue capillary perfusion, causes muscle and nerve damage. Features: severe pain out of proportion to injury, aggravate by muscle stretch and paresthesia. Causes: trauma, reperfusion, burns, exercise. Complications of missed compartment: muscle necrosis, myoglobinuria, renal failure, infection, amputation, foot drop from peroneal nerve palsy, Volkmann's ischemic contracture. Management. History. Examination. Investigations. Classic symptoms need no further investigations. Unclear diagnosis. Compartment pressures 30 mm over diastolic. Treatment: double incision fasciotomy, daily dressings of wound, prophylactic antibiotics. Re-examine in 24-48 hours to debride necrotic tissue and cover wounds. Tibial compartment fasciotomy. Compartments of the lower leg. Anterior compartment: tibialis anterior, extensor digitorum longus, extensor hallucis longus. Lateral compartment: peroneus longus, peroneus brevis. Posterior compartment: Tom Harry, tibialis posterior, flexor digitorum, flexor hallucis, plantaris, soleus, gastrocnemius. Indication: extensive soft tissue injury of lower leg, compartment syndrome. Measurement of compartment pressures: prepare sterilized skin, infiltrate local anesthesia, insert catheter into compartment, inject small amount of saline into cannula to fill dead space. Fill manometer tubing with saline and connect to catheter and pressure monitor. Ensure no bubbles or other dampening influence. 10 to 30 mm, less than diastolic. Impending ischemia more than 30 mm, less than diastolic. Impending or established compartment syndrome. Need urgent fasciotomy. Procedure: full-length longitudinal anterolateral skin incision 2 cm lateral to crest of mid-tibia from level of tibial tuberosity to just proximal to ankle. Anterior compartment. Incise fascia covering tibialis anterior and extend proximally or distally. Identify and protect superifical peroneal nerve, lies deep to intermuscular septum. Lateral compartment. Undermine skin to get to lateral compartment, avoid superficial peroneal nerve. Single longitudinal 1-2 cm posterior-medial incision just medial to posterior-medial border of tibia. Identify and retract long saphenous vein, incise deep fascia proximally to level of tibial tuberosity and distally to 5 cm proximal to medial malleolus, should be anterior to posterior tibial artery to avoid damage to perforating vessels. Used for later cutaneous flaps. Closure of fasciotomy. Wound should be left open plus vac dressing. Suture skin 3 to 5 days later. When swelling subsided plus or minus split skin grafts. Keep leg elevated. Complications: disruption of venous muscle pump, poor healing. Thanks for watching. Hope to see you again in more next video. But please do not forget to subscribe to our channel, like and share our videos. With my best wishes and best wishes of Dr. Ahmed.